Good morning. My name is Erica Stoor-Burning, and I'm here to talk to you about the normal exam of the head, neck, and eye. It is important to note the normal exam as it will make it easier to identify abnormalities in the future. We will start by examining these three regions to make you comfortable with the process. First, we'll go over the objectives. You must be able to identify the normal anatomy of the head, neck, and eye. Lastly, you'll be able to perform basic physical exam of the head, neck, and eye. The physical exam is performed in a preferred order. First, you'll note the inspection of the region. This allows you to look over the head, neck, and eye as a unit, looking for symmetry and any gross abnormalities. Next is palpation. This allows you a more detailed view of what's going on underneath the skin surface. Lastly, you'll be using special instruments and tests. Today, we'll be using the fundoscope. When you start with the head exam, you'll refer to the areas of the head corresponding to its underlying bone. For example, the frontal bone, the parietal region, the occipital region, temporal region, and the zygomatic. You'll also feel a major vessel in front of the ear. This is the superficial temporal artery which passes in front of the ear. When you palpate this region, it should be comfortable and it should not cause tenderness. Other glands in the region of the face include the parotid gland in front of the ear, the sublingual gland below the tongue, and the submandibular below the mandible. Next, we're going on to the head, scalp, skull, face, and skin. First, we'll start by inspection. You'll notice the small magnifying glass in the corner. This indicates this is a time for inspection. When you inspect the hair, you'll notice the texture, the pattern, and any hair loss. Also note any foreign objects, such as nits or bugs. Typically, the hair will hide any injuries located on the scalp, so you want to keep note on when you examine the scalp. You want to make sure that you are able to fully examine it. If there's a hair piece or wig, you should have it removed. You can kindly ask the patient to remove it herself or himself. Please make sure that they are comfortable with having it removed. When you examine the skull, please note the contour of the bones, any tenderness or deformities. You also want to note the suture lines that are located on the skull. This is especially important on children, infants, and especially neonates, as they have fontanelles that need to be examined. The face, you'll note the symmetry of expression, any involuntary movements, masses, or swelling. On the skin, you'll note pigment, texture, lesion, any abnormal hair growth, and any injuries, lumps, or lesions. On to the neck. There are many structures in the neck, many of which we will not go over today, as we'll save them for future lectures. For example, the muscles, the bones, the arteries and veins, and the nerves. Today, we will kind of focus on the trachea, the thyroid, and the lymph nodes in the region. We will still look at some abnormalities and review why they will be covered in other sections. First, we'll look at the surface anatomy of the neck. This will help us align for certain exams that will need to be performed. In men, you will notice that the cricoid cartilage is much more pronounced than the women. This will also be a helpful landmark when noticing the thyroid, which is typically located in the crux of the sternocleidomastoid muscles. The lymph nodes in particular should be evaluated. You want to note the size, shape, mobility, and tenderness. They should not be tender to move. They should be easily mobile, and they should not be readily visible when you look at the face and neck generally. Regions of the lymph nodes that are important to know are in front and behind the ear, that's the preauricular and postauricular. On the occipital region, the anterior and posterior cervical chains, the supraclavicular, submandibular, and submental. When you look at the neck from the anterior perspective, you'll note that the anterior cervical chain and supraclavicular nodes are accordingly where we expect. But just note the supraclavicular nodes may be located behind the clavicle and may need to push down to feel them more easily. Again, the lymph nodes should be not truly visible when you look at the neck. Any abnormalities such as increased swelling or tenderness when you palpate them is an abnormality and should be further investigated. Next, we'll do our inspection of the thyroid. You want to note any masses, symmetry, abnormalities, or swelling. The trachea and the thyroid should be midline. It should not be deviated to one side or the other. And any deviation is need for further investigation. When you inspect the thyroid, it's not always very easily to see, especially on larger necks. If you tip the head of the neck back, raising the chin, and place a flashlight on the tip of the chin and project it down, you can see a shadow of where the thyroid should be. You should note the equal distribution of the thyroid and the surrounding structures. An abnormal or irregular shadow may be indicative of increased swelling or some abnormality or mass on that side and should be further investigated. When you inspect the thyroid in the trachea, inspect it from the front, but when you examine it, if able, examine from the back. This allows you more mobility and more ease of application of symmetry for the neck. When you examine the thyroid, you want to place your fingers in the cricoid cartilage on either side. When you have the patient swallow, the lobes of the thyroid should rise up and fall down smoothly between your fingertips. If you notice that one side does not rise, this is a sign of an abnormality. The lobes on the lateral sides are much easier to palpate than the isthmus in the center, but both should still be evaluated. I wanted to show a video of things that you may see when you inspect the neck. Note the pulsatile mass in the neck and the jugular venous distension below. These abnormalities will be covered in the cardiology section, as typically these are vascular anomalies and further investigation will be needed. Next, we're going to review the eye. Starting with the eye, we will start with the pupil. It's in the center of the iris and it's typically very black. The reason why it's black is because the light is absorbed completely by the retina and makes the inside of the eye very dark. When you flash a light at the pupil, it should appropriately constrict. If the pupil appears cloudy or opaque, that's usually a sign of a cataract or previous eye trauma. When you flash a light in the eye, you should also note a red reflex, which is a reflection of the retina off the back of the eye. If you examine and do not see a red reflex, this is an abnormality and requires evaluation, but you will not be able to perform a fundoscopic exam. Next, the coating of the eye, known as the conjunctiva, is an epithelial lining of the sclera and inner eyelid. This is used to protect the eye from foreign objects and keep everything nice and lubricated. It should be clear and it should not be cloudy or irritated. Along the eyelids on the inside, it should appear pink and healthy. Any swelling or abnormalities in that region should be noted. Next is the anatomy review through the fundoscopic exam. I place two eyes next to each other so you can see where things should lie when you examine them. You'll notice that the retina is on the lateral side. When you typically start your fundoscopic exam, you'll note that there should be veins. These should be the first things you see. The vessels, which are typically 4 branches, one with each a nerve and a vein, an artery and a vein, which should go towards the optic nerve. The optic nerve is comprised of an optic cup and an optic disc. The optic cup is a much brighter center and should be much smaller, 50% smaller to be exactly, than the optic disc. If the optic cup is larger than 50%, it is noted to be abnormal and could be a sign of glaucoma. The fova and the macule are located on the lateral side. This is the vision center of the eye, meaning that when you flash a light into that region, it could become painful. So it's typically the last thing you do, and you have to prepare the patient that it may be uncomfortable. Next is the movement of the eye. The movement of the eye is controlled by 6 muscles and 3 cranial nerves. You'll note that in the picture to the right, I have marked off individually the typical 3 nerves, most of which is performed by cranial nerve number 3, the ocular motor. The other nerves, cranial nerve 4 and 6, each perform a job, but only move in one direction. When you're talking about the muscles of the eye, it is good rule of thumb to remember that the muscles that end in the word oblique typically do the opposite that you expect, meaning that the inferior oblique will move the eye superiorly, and the superior oblique will move the eye inferiorly. The contra to that is that if the muscle has the word rectus in it, it will perform the motion you expect, meaning the superior rectus will move the eye superiorly, while the inferior rectus will move the eye inferiorly. When you inspect the eye, you want to notice that it is positioned symmetrically on the face. The eyebrows are distributed appropriately. The eyelids are not swollen. They are smooth, and there is no nits or lice on the eyelashes. You want to inspect the lacrimal apparatus, look for any tearing, redness, or swelling. Also look at the conjunctiva and sclera, looking for any foreign bodies or jaundice. If the patient has a foreign body sensation, you may need to flip the upper lid down so you can inspect it properly. We can show you how to do this in the lab. When you inspect the cornea, iris, and lens, a tangential light should be approached from the lateral side towards the nose. If you notice that there is an increased shadow on the medial eye, that's usually a sign that the eye is being projected forward and needs further evaluation. Next, we'll go to the vital sign of the eye, which is known as visual acuity. This is performed with a Snellen chart. You want to stand the patient 20 feet away. This is what gives us the first number of the numbers we're familiar with when you think of vision. You will also note that there are two types of Snellen charts, one with letters and one with pictures. The most common one used is the one with letters. But for patients who are young or who do not understand the English language or are illiterate, the pictogram may be more comfortable for them. Both are acceptable and both can be used interchangeably. So typically, you stand the patient 20 feet away. You examine each eye individually and then both eyes together, meaning that you stand the patient 20 feet away and have them read down to the lowest line that they can. For example, if they can read down to line 4, their visual acuity is 20/50. The 20 means they were 20 feet away, and 50 is the corresponding refraction of their vision in that eye. You perform the test a total of 3 times, one for the right eye, one for the left eye, and one for both eyes. And you write down those numbers accordingly on your report. Next will be a visual field by confrontation. This is performed to find temporal field defects. A temporal field defect is a loss of your peripheral vision. This is performed by initially wiggling your fingers in front of the patient so they know what to look for. Then placing both fingers out of the field of view and slowly bringing them back. When the fingers are viewed by the patient, they will alert you. If you feel that the patient is not performing the exam well, or you feel that you're having an abnormal finding, perform the test with one eye at a time. Sometimes it's easier for them to do and can delineate more pathology. Next, we will go to the pupil exam. Typically, when you flash a light into one person's eye, it will constrict appropriately. You also have to note the consensual reflex, meaning the opposite eye should equally correspond to a constriction, even though the light is not flashed directly into it. This is a normal reflex. When you document the pupillary responses, you'll typically see PERLA, P-E-R-R-L-A. This means the pupils are equal, round, and reactive to light and accommodation. Next, we'll perform the extraocular exam muscles. You will typically move your finger in an H pattern. This will note the smooth motion of the eye. It should move smoothly from one direction to the next. It should not have any rhythmic beating, deviation, or one eye should not move more or less than the other. Once you completed the H, noted no abnormalities, move your finger close to the nose and have the patient still continue to watch your finger until you're about 8 millimeters away from the nose. The eyes should then converge in the center. This is called convergence. And this is normal to be able to do this, but don't go too close to the nose as it can be uncomfortable. Lastly, the fundoscopic exam. We are looking for the internal structures of the eye, which we previously mentioned. Make sure that the eye is dilated if you can. You will need to dim the lights of the room so that way it can be easier for the pupil to dilate, especially if you're unable to dilate the eye. Make sure you note the red reflex and you will look for any abnormalities around the vessels, the macule, or the optic nerve, which includes the disc and the cup. Next, we're going to play a video which will include how to properly do the fundoscopic exam. We will practice this in the lab, but this will give you a nice warm-up.
Hi, my name's Fiona, and in this short video, I'd like to show you how an ophthalmoscope works and how you can use this instrument to examine an eye. Many students, and qualified doctors for that matter, may tremble at the prospect of examining an eye. However, all you need is a system, a basic knowledge of the anatomy of the eye, and the ability to use an ophthalmoscope. Simple in theory, but clear instruction and practice in this skill is essential. First of all, you need to check your equipment and make sure it works before starting your examination. If the batteries are flat, or if a colleague has left the ophthalmoscope off its charger, there will be no light and you will not be able to see anything. Believe me, there's nothing more frustrating than a flat scope, so always make sure that when you finish using this equipment, turn it off and if necessary, return it to its charger. Now, there are many types of ophthalmoscopes, but essentially they all work in the same way. Firstly, you should be able to identify the on-off dial, and it's with this that you can alter the illumination. You need to ensure there is adequate light. Next, you should be able to find a dial that can be turned either clockwise or anti-clockwise. This adjusts the power of the lens within the ophthalmoscope and should be set for the moment to 0. Some ophthalmoscopes may come with a series of apertures or filters. As you can see, this can adjust the spot size. If you've got one, just remember small spots for small pupils and large spots for large pupils. Don't worry about the colours for now. Right, so you've checked your equipment, it works, and so you can begin your examination. First of all, as with anything, you do need to make sure you've cleaned your hands before you go near your patient. And next, you have to explain to the patient what it is you're going to do. Ideally, it should be good to use dilating drops, usually a very short-acting dilating drop such as tropicamide. Patients should be warned, however, that this may blur their vision for an hour or so. If you can, try to dim the room lights, particularly if you're attempting fundoscopy undilated. First of all, ask the patient to look straight ahead and place your hand on their forehead. At an arm's length, put the ophthalmoscope up to your right eye and look for the red reflex, swinging the light over to the left eye. Now, the red reflex is the result of light reflecting back from the retina. If no red reflex is seen, either your technique is poor or there's a significant problem with the eye regarding the clarity of one of the optical media. And from front to back, this could be due to a problem with the cornea, the anterior chamber, the lens, or the vitreous cavity. You will look silly if you attempt fundoscopy with no red reflex. Once the red reflex is identified, proceed to examine the right eye, your right eye to their right eye. Come progressively closer until you start to see retinal detail. Don't be surprised how close you need to come, although touching noses means you've gone too far. To focus the retinal image, you may have to rotate the lenses either clockwise or anti-clockwise. This is to account for potential focusing differences or refractive errors that may exist either with you and or the patient. If you wear very strong glasses, it may be best to keep these on. Right, here we go. Remember, the image you obtain will be highly magnified. You will not see a fundal picture depicted in textbooks, but a small circular image which you have to piece together to produce your own picture. Please don't panic, think logically. Have a system. The most likely structure you will see is a retinal vessel. Follow this either up or down to reach the optic disc. Starting at the disc, which should be nice and pink with vessels entering and leaving, remember the 3 C's: cup, colour, contour. Now follow the 4 vascular arcades, remembering each has a retinal artery and a retinal vein. Then ask the patient to look up, down, left and right, following the patient's eye at all times. It's here that you'll be allowed to pick up peripheral changes. Finally, ask the patient to look directly at the light. This will bring the macula into direct view. This can be very uncomfortable and should be the last thing you do. Repeat the above on the fellow eye, this time using your left eye. Not easy at first, but you must practice. So there we are. How to use an ophthalmoscope. Make the most of all the opportunities to practice this skill. You will have the opportunity to perfect your technique during our workshops.
So I want to thank you for taking the time to listen to my lecture about the eye, and I look forward to meeting you in the lab. And practice, practice, practice. Have a great day.